Hi, everyone. Good afternoon, and welcome to this month's Fireside Chat in recognition of Head and Neck Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our dedicated team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. My name is Ondrey. I'm the Community and Engagement Manager on our team, and on behalf of our entire team, thank you everyone for joining us today. As mentioned earlier, our discussion today highlights head and neck cancers. According to the National Cancer Institute, head and neck cancers account for about 4% of all cancers in the United States. However, by the time that they are found, they are often at late and advanced stages. So today we are bringing awareness to these cancers. In today's Fireside Chat, we'll explore the complexities surrounding head and neck cancer, the risk factors, symptoms, prevention strategies, the latest advancements in treatment and detection, and highlight some disparities as well. So today we are thrilled to have Dr. Frank Ondrey as our special guest. Dr. Ondrey is a professor of otolaryngology in the Department of Otolaryngology at the University of Minnesota. Dr. Ondrey practices head and neck cancer surgery and otolaryngology for mHealth Fairview at the University of Minnesota and St. Paul. He received his MD and PhD in biochemistry from Rush Medical College and Rush University before completing his surgical training at the University of Minnesota. He served as a senior staff surgeon at the National Institutes of Health before joining the faculty at the University of Minnesota. He is an expert in the multidisciplinary management of head and neck cancer of the oral cavity, larynx, and related structures. His research is primarily focused on early cancers of the head and neck and their prevention, and he has been a principal investigator on a majority of government-sponsored oral cancer prevention trials for over 20 years. He has served for many years on various review panels of the National Cancer Institute in Washington, D.C. He is also the co-leader of the Carcinogenesis and Chemoprevention Research Program at the Masonic Cancer Center. So it is safe to say that there is no better person to join the Fireside Chat this month to help us raise awareness about head and neck cancer. So we will be recording today's session, so you can refer back to the recording on the Masonic Cancer Center's YouTube page, and you can also share it out with folks who you might think would be interested. For University of Minnesota employees and spouse participating in the University of Minnesota Employee Wellbeing Program, you can earn your wellbeing points for attending today's Fireside Chat by completing the form that will be put in the link. That will be put in the chat. So the link to complete the form is in the chat right now, and it will also be sent in a follow-up email tomorrow. So before we begin, I'd like our audience to get familiar with using the chat feature, which is going to be located on the center of your Zoom window. During today's session, please use the Q&A feature to submit any comments, reactions, or questions that you have, and we have dedicated time carved out at the end for some Q&A with Dr. Ondrey. All right, without further ado, I will now pass things over to Dr. Ondrey. Dr. Ondrey, the virtual floor is all yours.
Yeah, thanks very much for having me today. Thanks very much for a very kind introduction. I'm an ear, nose, and throat doctor who's got a bit of a sore throat with some laryngitis, so I hope this comes true. I did test this with on another Zoom meeting today as well. So if we look at our head and neck cancer team, and part of the reason why I originally came here for my residency is because we serve a 4-hospital system, University of Minnesota, Regions Hospital, Hennepin County Medical Center, as well as the VA. Altogether, there's about 14 surgical members of the team that do cancer surgeries and cancer reconstructions. We have approximately 6 medical oncologists, about 7 radiation oncologists, and minimally 20 ancillary staff and rehabilitation staff for our patients. And that's been intact from when I started residency about 30 years ago, a little bit more than that. It's a very special feature of our cancer center. We were one of the first places in the United States to have a multidisciplinary head and neck cancer care team. We performed lead key clinical trials in surgery and chemoradiotherapy that became standards back in the 80s and 90s. We have a unique screening and prevention program, and we've led a number of the NCI clinical trials. And that was it was basically due because when I was recruited here, I was recruited to the Cancer Center to work in cancer prevention as well. And then we also have world-class tobacco research in the lung and in every other component, every other organ system. But we have special relationships with the Masonic Cancer Center and the carcinogenesis program to promote studies in tobacco sciences as well. So when we talk about head and neck cancer, we're talking about the lining tissues of the mouth and the throat, as well as the voice box. About 90% of these overall have been traditionally contributed by tobacco and use of alcohol, but also more recently, there's an emerging risk factor whereby human papillomavirus is a risk factor for certain tumors of the throat in the area of the tonsils. These typically form years after exposure, but sometimes they can grow quite rapidly once they're established. So there's a long latency period, and then sometimes once they start growing, some of them still grow kind of slow, but some of them will grow quite fast as well. Other tumors that we treat of the head and neck that are not really considered head and neck cancer in the vernacular would be tumors of the saliva glands. There's saliva glands on the sides of our face and below. Those are both benign and malignant tumors. There's skin tumors that people will get that can spread to the lymph nodes. That's not typically considered a head and neck cancer. There's tumors of the linings of the sinuses, of the jaw, things of this nature. And then because we're sun exposed, a lot of melanoma tumors actually occur on the head and neck as well. But those aren't part of this discussion. Those are all things that our team members treat, but they don't fit into the head and neck cancer awareness month, which is really what we're kind of focusing on here. As I mentioned, there's a latency of these cancers, and it can be long, which is 20 or more years. And the reason being is that tobacco and alcohol use can gradually make mutations in cells. And then once those mutations accumulate to a certain degree, then they'll form precancerous lesions and tumors as well. And then what happens in the more recently described HPV tumors, they can subvert normal cell growth processes and speed them up while also driving cancer formation. Just a little bit of science in here, because there's a couple of cartoons that I made a long time ago that kind of drive home the point of what really happens during tobacco-associated carcinogenesis. So what you see if you look at chromosomes, and I have the 9 chromosome here because it's one of the ones that would be affected greatly, is that over the course of 15 years or more, you use tobacco smoke, and tobacco smoke will cause these little lesions on the chromosomes actually. And what ends up happening is they can cause quite a bit to the extent where there's a moth-eaten chromosome, for lack of a better term, and then you have your 25 years gone by, and then what you kind of have is you have the circumstance whereby all the genetic damage that's on these chromosomes can be accumulated. And what that really means is it means that to go from normal to cancer, you have this 20 or more year period of time. You accumulate these genetic and chromosomal defects, and then you ultimately will get cancer. Now, it's still pretty rare. If you look at all the smokers in the United States or ex-smokers, even if it was 20% of the adult population, that would still be something like 50 or 80 million people or something in that nature. But in reality, we only see about 45 or 50,000 head and neck cancers forming a year. So it's relatively small for the number of smokers that there are. So the critical events that occur during head and neck cancer formation is that you need to increase the cell growth. Then the cells have to be able to grow on their own. Then after that, there's decrease of the cell death that happens. And these are all things that are caused by the accumulation of these genetic defects that occur on the chromosomes. And then what ends up happening is at a critical size, new blood vessels will feed a tumor. Then it will locally go into the tissues and cause pain and bleeding and things of this nature. And then it ultimately will end up in the lymph nodes of the neck primarily. So when we talk about the spread of mouth and throat cancers, they occur locally in the mouth. They usually get to a certain size and a certain depth, and then they will involve the lymph nodes of the neck. But they don't randomly spread all over the body like other cancers can. The other thing about them, and this speaks a little bit more to the kind of research that I've done over the years, is that when you have tumor development, there's usually an irritated and inflamed area that will kind of start, and that may start because of poor dental care, because a tobacco user might not have the best healthiest gums and things of this nature. The tobacco itself can form inflammatory processes within the mouth itself, and then what happens is they go from these precancerous states where everything can look pretty normal. And then once they get to a certain amount, mouth and throat cancers are often associated with what's called immune unresponsiveness, whereby the immune system is not able to fight off these processes that well anymore. And the reason for those immune suppressions are several. It could be because of the disease itself. It could be because things like tobacco or alcohol use will suppress immunity. And it could be that since these occur in older folks tend to have less good immune systems than younger folks. And in looking at this, I have a diagram that I've had in talks for just about 25 years now, is that you have the circumstance where there's carcinogens in tobacco or alcohol, then there's this chronic irritation that kind of go hand in hand. And then over time, they'll cause a lot of pro-inflammatory processes within the cells. And in particular, there'll be a lot of these things that are called pro-inflammatory cytokines. They're small proteins that will signal inflammation or immunity in certain regards, but they're signaling these types of things in a field where there's not that good of an immune system actually working. And we did some experiments a long time ago with a fellow who's now in practice in town, Dr. Rohrer. We looked at different types of tobacco carcinogens, and what we're able to see is when we dose these carcinogens at lower to higher doses, we would see that in the test tube that these pro-inflammatory substances would go up, and that they go up sometimes very dramatically. And so one of the things that we've sometimes tried to target in our clinical trials is whether or not we could tamp down on these carcinogens that are causing these inflammatory substances to form. So one method is to try to combat the inflammation. And these are a couple of the things that are associated with the inflammation, these things that are called cytokines. Now, it's worth going over a fair number of the statistics on head and neck cancers, why they form, how we do in Minnesota. So in the system of head and neck cancers and the fact and how we account for those and how we number them and how we put them down in our check pads and everything else like that, the check boxes, is it's a classification that separates out the digestive tissues. Now, when we eat, those are the digestive tissues. We put food in our mouth, so the tissues in the mouth, and then we swallow, and that goes into the esophagus, into our stomach. Well, the head and neck cancers kind of stop where the esophagus starts, even though it's kind of a continuum, of course, when we eat, they stop where that starts. And then since voice box cancers, they're a rare type of cancer, but that's part of the respiratory system, because when we're breathing, we have to get air past our voice box. So we use the word like aerodigestive cancers, upper aerodigestive cancer. We use those types of terms because the two areas are kind of separated. The digestive cancers of the mouth and the throat are separated from the ones that are in the voice box and into the lungs. So it's a little bit confusing sometimes when you look at the statistics on this. I'm going to focus a little bit more on just the oral cancers, except I have a couple of slides where I'll talk about the voice box cancers as well. When we talk about these HPV-associated viral cancers, so you could have Michael Douglas, the actor, made a big point of having a virally associated throat cancer. Well, these are cancers that occur in the regions of the tonsils, not really in the mouth part where the tongue is, and not really in the voice box. They're more likely occurring in the area of the tonsils, and those again form years after exposure to the virus. But when they form, their latency is a little bit less. So we'll tend to see these HPV-associated cancers at a somewhat younger age than we will when the folks who are having tobacco-associated tumors. Now, if we look at how many of these there are a year, I did something kind of easy. Nowadays, the federal government's pretty good about putting up the statistics from the Center of Disease Control and the National Cancer Institute, American Cancer Society. But for the mouth cancers that go back to the throat, not the voice box, there's about 45,000 of those per year. And if we look, the vast majorities are occurring in white individuals. Black individuals have about 3,500. There's about 300 in Native Americans, about 1,700 in Asian and Pacific Islanders, and about 3,000 in Hispanic individuals. So that's how you get up to about 45,000 of these per year in looking at the statistics. Now, if you look at the annual number of new cancers, what you'll notice here is this is a circumstance whereby these oral cavity and oral pharynx cancers are increasing. They didn't count cancers that well during the pandemic, so there's going to be a lag there because people just didn't go into the doctors often for some of these views. But what's important about this is if we look at the next slide here, this HPV phenomenon is really kind of a more recent phenomenon. We can test for it now. When people come in for cancer diagnosis, we have staining tests that can be done on a tissue. We have different kinds of viral tests that can be done. But if we were to march this back from 1999 to 1970, this whole line here would be kind of flat. The federal government site only gives us the last 20 years, but it's safe to say that this whole rise of the amount of oral pharynx cancers, the ones in the tonsil, it's gone from about 30,000 a year to about 45,000 a year now. And this is mostly for HPV reasons. So when you look at this segment of the mouth and throat cancers, almost a third of these are now contributed by HPV. A personal record in diagnoses, I guess, it's not a kind of record I'm proud of, but I did diagnose 6 of these in 1 week a number of years ago. So it's not, I could get 20 or 30 or 40 of these folks that will come into my clinic a year for treatment once they have HPV-associated malignancy. Now, when we look at the age of people, for the most part, we're still, if we look at the age that we're talking about, this is age 40 to 50, 50 to 55, 55 to 60. The average age of diagnosis is right around 60. But when we look at the highest age of incidence, we're in this range of about 55 or 60 years of age to about 80 years of age. So it really is a disease kind of aging. In the olden days, when people only had a life expectancy of 65 or so, you wouldn't see perhaps as many of these if you correct for age, simply because people didn't live that long. But this is a disease of aging, and it's important to note that. And this does go along with the traditional risk factors of having, people starting smoking in their 20s or something along those lines. And then you have this whole time go by before people are actually developing precancers and cancerous lesions and cancers that need to be treated. Now, another statistic for both sexes is how many per 100,000 diagnosed. So it's again a little bit more of a disease for on a population control basis. It's a little bit higher for whites than it is for Black individuals. It's a little bit higher for Native American individuals that are not Hispanic, and a little bit lower again for Asian Pacific non-Hispanic individuals, and then a little bit lower for Hispanics. So for the oral cavity and the oral pharynx, when you control for age, it is mostly in a corrected fashion occurring a little bit more likely to get this if you're white, by a little bit. If you compare it to African American individuals, Black individuals, it's about 50% higher for whites than it is for Blacks when you control for age. Now, this is one of the ones where I keep this kind of a figure always in my talks, because this kind of shows what's happened to larynx cancers. So the voice box cancers that people get, where you have to have your voice box removed and talk with one of those speaking type devices, those have been going down in rate. Over the last 20 years, they've decreased about 30% or so. And I think what's happening in this group of individuals is that when I would see patients at the Veterans Hospital or things like that, they would get these larynx cancers. A lot of these people were quite heavy smokers. They were smoking more like a couple of packs per day. And now with all the tobacco taxes and things of this nature, you have to be pretty well off to be able to smoke 2 to 3 packs of cigarettes per day. So I think one thing that some of the smoking taxes and smoking programs have helped is there's probably fewer larynx-associated cancers because they require a little bit more smoking than the non-larynx-associated cancers. Now, another thing that's very important here that was mentioned right at the very beginning is what stage these tumors show up at. Okay. Now, if you look at this, there's localized tumors are ones that are just in the mouth or the throat by themselves. Regional tumors are in the mouth or the throat, plus the area of the neck. And then about 10% of folks will show up with maybe a second tumor in their lung or something like that, or a third tumor in their lung elsewhere. And then there's always people that show up in our statistics that don't have a good staging. That's over here. But if you look at this and you go forward, there's about an 80% or better survival when you have just localized disease. And this would be of all the sites of the mouth and of the throat. Now, when we go over to the more advanced ones, as soon as you put a lymph node in someone's neck, and it's spread beyond the localized site in the mouth, you're having a circumstance where survival is now only 40 to 80%. So you can lose half of your survival on the advanced stage disease of the mouth and throat cancers simply by having them be in a longer period of time that goes by. It could be because some of these tumors do grow fast and will throw off lymph nodes pretty quickly, but a lot of people will think that it's mostly because there's a long time once a person has a lesion in their mouth that's cancerous to be diagnosed. Now, when we look at Minnesota, the highest survival rates for all stages of cancer are the states that are in blue. So there's no question that Minnesota is a top 10 state for survival. I've looked at a figure like this a number of times over the past 20 years, and well, I think that there's a couple of reasons for this to be the case, but clearly there have been outstanding head and neck cancer programs run in the otolaryngology departments at both the University of Minnesota and also down at Mayo Clinic. And they've been staffed by ear, nose, and throat doctors for the past 40 years or more. So there's been a lot of very excellent care by highly regarded subspecialists in taking care of mouth and throat cancers in the state of Minnesota. And then in our own training program at the University of Minnesota, a lot of our graduates will go on and practice in the state of Minnesota. They're around a lot of patients, and they help out with a lot of cancer operations. And when that's the case, they're probably a little bit better than a lot of other states are at being able to detect these patients when they come into their clinic. So I think that we do a pretty good job in Minnesota. We're clearly a top 10 state for survival overall. Now, for this part of the talk, you have some, and it wants to drift here. So it's important that if we could promote finding cancer sooner, that would be a good thing. I have a little bit more of a talk on that too, but that can often be done in a dental office. It can be done sometimes with self-awareness. We'll have these talks here not infrequently. I'll give continuing education talks to both medical and dental professionals at Health Partners and at the University of Minnesota. I've even talked at North Memorial. So I think that the awareness part of this is a good thing for the dental community and other people to know, because they might come in a little bit sooner when they feel that something's not right in their mouth. And then as we decrease or eliminate tobacco or alcohol use, the heavy smoking clearly is going down, partially because of cost, but to have that as a primary prevention goal is a good idea. The word is out still on some of the things. Is vaping a good substitute or not? We don't know that. A lot of times people in tobacco sciences will feel that people who are vaping under certain circumstances, that may be more of kind of an entry pathway into other forms of tobacco use. But the word is still a little bit on that. So we still want to discourage alcohol and tobacco use to be moderate to minimal, and really eliminate smoking if we could. And then to utilize the HPV vaccines, these HPV-associated tumors, in 20 or 25 years, they would almost be eliminated if there's more of a universal vaccine for people who might be at risk. And this is we're just way onto some national things on the TV. On TV, I've seen it in commercials. We have about a 50% HPV vaccine uptake in the state of Minnesota. It's not as good as some states, but if we look at some other countries, like Rwanda has about a 99% vaccination rate for HPV because it's mandated in that country. So there is a room to grow in our capacity to prevent these tumors from HPV vaccines. And then, like I mentioned, the promotion of screening programs and the teaching of screening to other professionals is a little bit of a sort of cancer prevention evangelization by those of us who treat these diseases is good as well. So now just a couple of pictures, hopefully not too gross, but I'll show a couple of things about how these lesions will appear and why they worry us, and what are the kind of symptoms that will set us off for doing a biopsy and things of this nature. So if you look closely here, this is one of my patients from quite some time ago. They had this lesion. This could have easily have been from chewing tobacco use. There's their teeth on the left side. There's the cheek on the left side. The thumb and the finger are kind of stretching out at the level of the lips, and here's a lips and over here. But you have this white lesion that's here, and it's this would be considered a leukoplakia lesion. Sometimes these things, depending on the circumstances, will get biopsied. Oftentimes, if they're present for a long time and they don't go away, you go ahead, you'll do a surveillance biopsy on this. The cancers of the cheek are a little bit more rare than cancers of the tongue. So in going ahead and treating something like this, you try to go ahead and remove anything that might be eliminating, that might be used to eliminate the circumstance. For example, I'll just have someone that comes in with something like this, put chewing tobacco in the other side of their mouth. I know I'm not going to be able to convince them to stop chewing tobacco, usually right at the first visit, but sometimes a lesion like this will resolve on its own. Now, here's a very close up of one of my other patients a long time ago now, but this is under the tongue. This is that little frenulum that we have under the tongue. The teeth are here. This is the floor of the mouth. And this whole white area of lesion here is, again, it's painless. If I were to rub on this, there's nothing that looks like it bleeds. It doesn't ulcerate or anything like that. But because it's in the floor of the mouth, I'll do one examination to see if it's going to go away or not. And then at their second examination, they're going to go ahead and I'm going to biopsy something like this, because these types of lesions could harbor precancerous cells. Because it's not likely to be a cancer just looking at it. I can't remember if this thing ever turned into a cancer or not in this individual, but this is something that would get biopsied. We talk about biopsying. A very strange characteristic of these lesions is that if we go ahead and we decide that we're going to remove these lesions, they frequently return. Because it's important to remember from the very beginning that once a person has used a lot of tobacco, their whole mouth is kind of diseased inside in terms of the genomics. So taking out and removing leukoplakia lesions that are not cancer does not really prevent whether or not that person's going to get cancer, but it gives you a signal that that person's at a higher risk. So and when we talk, just a little bit of a reminder again, when we go ahead and we use these terminologies of what are mouth and throat cancers, what are the organ sites, we divide everything in the mouth, whether it's the inner lip, the gums, the hard palate, soft palate, we divide things into about 45 sites. And a lot of times those tumors will behave slightly differently depending on which one of those anatomic sites they are in. So it does really, it speaks to the fact that you want to have an otolaryngologist that, at minimum, an otolaryngologist that might see a lot of head and neck cancer cases to be the one who's doing your surveillance and your treatment potentially once you have an abnormal lesion. When we look at what the basic components are, it's the vestibule of the mouth, which is the inside of the cheeks. You have the tongue, the floor of the mouth, the roof of the mouth, which is the hard palate, and an area that we call the retromolar trigon. And I kind of have a diagram. And in this type of a diagram here, we have something where if you're having someone open up their mouth all the way, we're going ahead and we're having people look on top of the tongue, look at these areas around the inside of the teeth, really kind of go ahead and stretch out these areas so we're able to see the inside of the cheeks. We look past where the tonsils are, we're able to see into the throat. And then these areas that are right in the inside here, they can hide tumors sometimes. They're the area of the inside of the gums. And we'll often use two separate tongue blades, or I'll tend to use these long wooden Q-tips as my way of separating out the structures of the mouth, so I can get a good examination of that whole area. And then I'll go ahead and I'll feel around all those areas as well. So basically, I'm going to be examining the whole area. And oftentimes the dentist, when you go for a cleaning, the hygienist, they're doing all that nowadays. That didn't used to be done back about 30 or 40 years ago. It was really something that maybe some dentists did. But at the dental school, the gentleman by the name of Nelson Rodas, he's not really much in clinical practice anymore, but he taught for about 40 years. All the dentists how to do good mouth cancer screening examinations. And we give some talks over there. I'm part of the faculty at the dental school for some of this work as well. Then the other thing that we talk about, and this is a little bit more academic, but we talk about these zones in the neck. And we divide the neck into a bunch of zones, whether it's underneath the chin, closer to where the side of the neck would be on one side, if it's kind of in the back of the neck or going down the neck. But we divide it into 5 zones, and that's how we figure out or try to predict where cancerous lymph nodes might go when someone has a cancer. So basically what ends up happening is there's kind of a logical spread. Usually the first lymph nodes that are closest to the anatomy of the lesion of the cancer itself is where the lymph nodes will often show up with tumors. So it's based on just the knowledge of the lymphatics of the neck. So if you remember, if you get a strep throat, you're going to have a sore lymph node on the side of your neck. If you had a tonsil cancer, that's the lymph node that's most likely to be positive. It's not going to be something that's down in your neck above your chest on the opposite side. It's kind of an early progression to most, but not all, of the mouth and throat cancers that will develop. Now, just a tiny explanation of the staging system, just how we look at it, because a lot of people do get cancer, and what does the staging system actually mean? Well, it's called a T&M system, and T is for the size of the tumor, N is for whether or not there are lymph nodes that are involved, and M is for metastasis, whether or not there is distant spread of a tumor. So then when we go ahead and we derive the stage of a cancer, we derive it by adding up the T, the N, and the M staging and come up with the final stages of the tumor. And as a basic for inside the oral cavity, things that are less than 2 centimeters, which is about 3/4 of an inch, are going to be considered a T1, or the smallest cancer. The T2 cancers are going to be up from about 3/4 of an inch to almost 2.5 inches, close to that. And then once they get to be much bigger than that, they can be T3 or T4 size cancer. So when people are having tumors this big, they're usually having a fair amount of difficulty speaking if it's in their tongue. Up to half of their tongue might be involved with that sort of a cancer. And once they get to be this T4, stage 4, they're involving multiple sites. So that would be a tumor that would involve potentially the tongue, but it would also maybe involve the jaw, would maybe spread down into the neck, even to the skin of the neck, but places that want to spread locally by this tumor gradually expanding over time. And then the basics of the lymph nodes, we have what's called N1, N2, and N3. That basically has to do with the size of these lymph nodes. So if it's less than 3 centimeters, it's N1. And this is just to kind of like, just for completion's sake, for how one derives a staging of a head and neck cancer. Now, when we look at what we do to diagnose this, we go by symptoms, and we'll also go by we'll go by symptoms, and we'll also go by physical examination. So a lot of these things that one has here are for more advanced cancers, which is how most of these will show up. So for the voice box, people will have aggressive hoarseness over time. For tumors that would form in and around the tonsils or the back of the tongue, you might have difficulty swallowing. You might have oral bleeding with this. Once a tumor ulcerates, it will usually cause some oral pain, but before it really ulcerates and kind of grows deep into the muscle, there might not be pain associated with it. You can have painful swallowing with this, in addition to difficulty swallowing. And then for some tumors that are down by the throat, they will send off pain to the ear on that side. So oftentimes when I have a person that comes into my clinic with ear pain, I really want to examine the area of their throat next to their voice box, because there can be tumors in that area that would be associated with ear pain. And sometimes that might be the patient's only symptom. And then when we look at the observation of the entire mucosa of the mouth, under the tongue. That's why, some of us will still use these old head mirrors that you can kind of look through and shine a light from a mirror inside the mouth, like you see almost in like cartoon strips and stuff now. But a lot of us will also use these fiber optic lights that you're able to look, and you're able to use both your hands to examine at the same time, which is very, very helpful. And we also carefully palpate the neck. Once a person has a neck of a certain size, you're not able to feel things that big, but in a very thin person, you can feel abnormal lymph nodes down to a level of about 1/2 inch or so. And then what we'll also do is we look at the back of the throat with either a mirror or one of these flexible scopes that can go through the nose to look at the back of the throat and voice box as well. Now, if we saw those other pictures, this is an actual tumor that's a little bit more than those other ones. This cancer, when I measured it, it was over 2 centimeters in size. This is the tongue, Hopefully it's not, hopefully it's not grossing people out too much. But just looking at this here, one could immediately tell that this lesion is nothing like those other two that I showed you. Those other two were flat and plaque-like lesions. When I was to go ahead and feel something like this, I could go ahead and rub out a lesion like this with a Q-tip, and it's probably going to bleed. That ulceration is going to cause pain, just like a bad cold sore would. And when you feel this type of a lesion, this lesion is going to have some thickness to it as well. You're not just seeing an ulcer that's right at the surface, you're seeing an ulcer that's probably also going down into the muscle. And in this one here that I see, you're able to see that tissue below where the ulcer is even bulges out. So when I was to go ahead and measure this from side to side, this was somewhere between 2 and 4 centimeters. And that would have to be resected. The treatment for that's a resection, but that would be a cancer compared to these other types of lesions that that can sometimes be confusing. But I wanted to give a very kind of a stark example to show you that these white patches look a heck of a lot different than something like this. Now, when we go ahead, and the principles of treatment for this is that when lesions meet a certain size, we can't just go ahead and take the lesion out of the mouth, but we also once it might be that 15% of the time or so, you could have lymph nodes in your neck that might have cancer in them based on where the tumor is in the mouth and based on its side. We'll go ahead and we will electively take out and do a neck dissection on that person as well. Nowadays, that neck dissection is called a modified radical neck dissection, sometimes called a selective neck dissection. In the olden days, they were all called radical neck dissections, where you took out a heck of a lot of extra tissue over what you needed to. But that gentleman in that person in that last picture had a T2 size lesion. So that's one that would automatically get the neck dissection at the time, because that person would have more than a 15% chance of having lymph nodes in the neck, even if I couldn't feel them. The principles are that we go ahead and we remove the cancer with a cuff of good tissue. So I've kind of almost outlined here how much one would take out. You want, for a tumor like this, you want to take out an extra centimeter on all sides. So for something like this, you're taking out somewhere between 1/4 and 1/3 of the tongue to remove this tumor. And then this person, and then what we do at the end is all the tissue around this side here, like where this red is outlining, we take out strips of tissue there. And we have that looked at under the microscope right away to just make sure that there's not any tumor that's going much beyond where we actually see it. And then in this tumor, in this patient here, we'd also remove the neck nodes of the lymph nodes of the neck on that same side as well, a good portion of those. So that would be the example of how we would do surgery on something like this. Now, there's a couple of basic treatment principles for what we try to use for treating a lot of these types of tumors. So as a general rule of thumb, for the T1 and the T2 tumors, if they're not too thick, they are treated equally successfully with surgery alone or sometimes radiation alone, not chemotherapy typically. Chemotherapy is usually reserved for the large stage tumors, but one or the other can be used if it's stage 1, stage 2, T1, T2. What'll happen sometimes is for one T2 tumors that are in the voice box, sometimes a better result for voice and speech might be given for radiation. For a T2 size tumor in a voice box where you're taking out a whole, maybe even half of a voice box out from the inside out, that person's going to definitely be hoarse. Sometimes if that person gets radiation treatments, they might not have much hoarseness at all, if any, even after they're treated. And sometimes tumors in the tonsil and the pharynx will be treated with radiation by itself. But surgery, whether it's with a robot or a laser or just cautery like we use, those are all going to result in about equivalent types of survival for the stage 1 and stage 2 cancers. Now, when we look at these stage 3 and stage 4 tumors, T3 and T4 tumors, basically all of those are just about going to need more than one modality. So for something like this, a person will go ahead and maybe they'll start out with surgery where they go ahead and you take out part of the tongue, like I mentioned. And let's say on that last tumor, we had a circumstance where there were some lymph nodes that were positive in that neck as well. Well, that person would then go on postoperatively, and they would maybe get 30 radiation treatments daily, once a day for about 6 weeks. And that would be what's called combined modality treatment, whereby a person has gotten surgery plus radiation therapy. Surgery and radiation are kind of the most common combined modality treatments. There's times when You may want to preserve the fact that a person would have to have their whole tongue removed or something like that. That person might get chemotherapy and radiation therapy together rather than surgery and radiation therapy. But generally for the small tumors, you're going to have an 80% or more 5-year survival rate. And then for tumors that are larger, it's going to be in that 40 to 80% range. Now, this is something that I put out here towards the end of my talks, because this actually goes back when they were doing a different way of showing the statistics. But if you look at breast cancer in red, and you look at colorectal cancer in green, and then you look at oral and pharynx cancer in blue here, what you'll see is that somewhere around 1990, 1985, the slope of this line, the survival was really getting better and better and better. And these tumors, from the breast cancer tumors and colon cancer tumors, they're almost about 20% more survivable when they were back when I was in medical school compared to that. And now if you look at the head and neck cancers, our survival, we're only improved about from to about by 3 or 4 or 5% over what we were before. An exception are these HPV cancers. The HPV cancers do very well by however you treat those. And those patients that have an HPV-associated cancer do so well that they're not even included in this type of a graph. But that's the exception to the rule. But for the mouth cancers and for the larynx cancers, we're not having as much of a massively improved survival like what we've seen in breast cancer and colon cancer, for example. And some of this does come down to the prevention and screening. We've had mammography for breast cancer for a long time. We've had things like colon endoscopy and Cologuard as an emerging technology to use for colon cancer detection. But for oral cavity cancers, there's not really a recommended screening program by age out there. There's a light recommendation from the American Cancer Society that people that are smokers and non-smokers should have their mouth examined every 3 years to look for tumors. But there's not a standard recommendation for that. So that was part of the reason why I was asked to start this cancer surveillance program over at the University of Minnesota quite some time ago. Now, and when we also look at where are their chemo prevention drugs, well, there's no question that women that will take tamoxifen or things like that is a good cancer preventative for women who are that. Aspirin-like drugs are recommended for some colon cancer preventions. There's something called finasteride for prostate cancer that's in use as well. But with about 45 years of cancer prevention research for taking repurposed drugs or vitamins or anything else like that, there's been a long, long history, almost a half a century, and we've only gotten 3 drugs out of that. I mean, we just looked at the number of cancer treatment drugs in the last 5 years. It far outweighs the amount of cancer prevention drugs that we've had over 40 years. So so in my own program, what I try to do is I try to go ahead and utilize well-tolerated diabetes medicine to reverse precancerous lesions. It's been a successful strategy for funding, and we're on our 7th clinical trial over the past 20 years to try and come up with a definitive way of combining these agents or giving these agents so that they might go on to a more advanced stage clinical trial. But as of now, we've only gotten to the 2nd stage of clinical trials. I've done trials where maybe 30 or 40 patients will get a drug. They'll have enough for a response whereby it looks promising, and then we'll go off and do a randomized trial. And we're in the midst of a couple randomized trials, nowadays in the country. So we're getting there, but it's been a very slow go of things, unfortunately, for these mouth cancers. In a way, the search we're searching for the holy grail for oral cavity carcinomas. That's for certain in terms of prevention. Here is a patient long ago that was on one of my clinical trials. This would be one of these leukoplakial lesions. This person got a 12-week treatment of one of the diabetes drugs, and then at the conclusion of the treatment, the lesion went away. So these drugs, we have been showing that these clinically work. We did follow up for a long time on this individual, and to my knowledge, this person did not get a new lesion. So that would really be considered kind of a cure of a precancerous lesion. Now, in some conclusions here, head and neck cancer overall is increasing in incidence, but it's not because of what I would think, like more people smoking or something. It's mostly due to these HPV-associated tumors. And then, unfortunately, the cure rate for smoking and tobacco-associated cancers are quite stagnant. And then prevention and screening by either risk reduction, fewer smoking or less alcohol intake, and examination may allow for earlier diagnosis. One thing I did not talk about here are that 10% of people that don't have a lot of tobacco and alcohol as uses. So there's a variety of mouth conditions. There's people who have gotten transplants like and they get graft versus host disease. There's a population of patients that have Fanconi anemia. It's a rare disease, but we see a lot of those patients at the university. There are people with oral lichen planus, a relatively common condition, but 1 to 12% of those patients will go on to develop cancer. In the last year, I've had about a dozen or so non-smokers show up to my clinic that have had oral lichen planus or another disease, and 2 or 3 of them showed up with very advanced disease that had oral lichen planus in the past. They showed up with stage 4 disease that grew rapidly, and I had one patient that was up from the Brainerd area that after many years of a lichen planus diagnosis, they ended up going directly to hospice, actually. So so these conditions that are inside the oral cavity, we do want to pay close attention to. And when lesions are lasting more than about 6 or 8 weeks, it's reasonable to have those things referred to someone who is familiar with a number of these lesions. And interestingly, some of the things that hurt the most, like oral lichen planus, can hurt an awful lot. Cold sores, if you get them a lot, will really hurt. The most painful things that you could tell what they are, those are not the highest risk things for cancer, and that cancer often will develop in these areas of the mouth where they're painless white masses, painless white lesions. And I think with that, I'm going to turn it back to for questions.
Dr. Ondrey, thank you so much for providing such a comprehensive overview of head and neck cancers, prevention strategies, emerging research, and for sharing insights into some of the treatment methods. I am such a visual person, so I really appreciated the photos that you shared in your presentation. So as we move on to the next phase of our session today, we invite your audience to join the conversation. So this is the portion of our fireside chat where you can engage directly with Dr. Ondrey. So please enter in questions that you have using the Q&A feature. We've had quite a few questions already added. I'm just going to go ahead and share my screen because, as you all know, it's not a fireside chat without getting our fire started. So just to kick things off, we've had quite a few questions come in already. So first one here, Dr. Ondrey, does having a tonsillectomy have an impact on head and neck cancer later on in life?
Yeah, that's not shown to be the case, the best that I could tell. But it is brought up. One thing that's brought up is that some of these HPV-associated cancers, if one was to look at a tonsil, and if you were to make a fist and put a tiny piece of paper in the middle of that fist, sometimes these HPV-associated cancers will show up in the tonsil crypt. They'll basically be invisible. So I think there's an opportunity for people that do end up getting their, and it's not a good opportunity, but if you have your tonsils, a head and neck cancer that would be HPV associated, you'd hide in that tonsil a little bit longer than it might if someone didn't have tonsils at all and the lesion just appeared in the back of the tongue or kind of on the roof of the soft palate or something like that. But it shouldn't have an impact overall.
That it doesn't have an impact. So we have some HPV related questions. So can HPV be transmitted through sharing food or drinks or kitchen utensils? And then follow-up question, is your risk of HPV associated head and neck cancer reduced if you don't have tonsils?
Yeah, so those are both really good questions too. It's HPV cancer, some of the epidemiology is a little bit tricky sometimes, because what ends up happening is that when we look at the classic HPV cancer, which is cervical cancer, and then we look at how many people in the United States have been infected with HPV, either currently or in the past, minimally 10% of the adult population has been infected with HPV somehow. And in otolaryngology clinics, unlike gynecology clinics, we do not do We do not, we're kind of embarrassed sometimes about doing very comprehensive, you know, sex histories and things like that of individuals. I will say that there are certainly times when I've had patients who have HPV-associated cancers that I can't imagine that they had any sort of a sexually associated risk. And the fact that we have 30 million or more Americans that have been infected at some point in time in the past. I don't want to comment on casual contact because I'm not an HPV biologist, but I don't think that that like I worry a little bit that what all the modes of contact for HPV can be, but it's nothing that you could even mitigate against because there's not really any any signs of an HPV associated infection in your mouth at all. You could have it detected, but if it's detected, what do you do with it? There's not even screening that we do for HPV associated cancers because the hit rate is so low. If you look at 30 million adults that might be at risk, and then you have only 10 or 15,000 that are getting this on a yearly basis, that's an incredibly small numerator for the denominator to almost institute screening programs. So that's why we've often recommended that HPV vaccines might be a better mitigation type of technique for this malignancy.
So another question here, we have lots of questions, so we will try our best to get through as many as we can in the time that we have left. So has vaping been around long enough to get information about carcinogenesis?
Yeah, there have been around long enough. There's something I want to take sort of the high road and kind of like worry about it as a way of entering into things. But when you look at vaping by itself, it's primarily nicotine delivery. So you do eliminate a fair amount of the types of tars and things like that that are traditionally considered to be tobacco carcinogens. But what you replace that with a little bit is that a lot of the ignition capsules and things like that are part of the vaping category, some of those have things like chromium in them. Chromium does increase the risk for lung cancer quite a bit. It's a heavy metal. We have started a global tobacco program through our division at the Cancer Center. Dr. Irina Stepanov is in charge of that entire division, and we're on the verge of testing many of these alternate tobacco products in a facility that we run, whereby we could actually do high quality experiments to examine what human individuals or what animals might be exposed to when you expose them to vaping.
And I will just put in a quick plug. If anyone's ever interested in touring Dr. Irina Stepanov's lab, you can do that. So there is a form on the Masonic Cancer Center's website to tour some of our research facilities, and specifically Dr. Irina Stepanov. And so there's another question here that's asking about the reason for such high incidence among whites compared to other racial ethnicities. Is it because of smoking distribution? Does that play a role? Or does genetics play more of an important role? Can you help explain some of that discrepancy?
Yeah, no, what we did is we actually I had two medical students from North Dakota that have been interrogating all the tumor cell genome atlas. It's a publicly available database. And we try to look for the African-American patients and Black patients compared to the white patients. And we run into a couple of things. There are some genetic disparities between whites and Blacks, that's known, but the specimen size for the African-American and Black specimens, there's not that many specimens, and they're mostly of advanced stage cancer. So we don't get the best answers on that. And I don't know what might be somewhat a little protective for Black individuals versus whites in terms of it having a little bit higher of an attack rate for white people. I don't know that off the top of my head. And when we did the analysis of the tumor cell genome atlas, there's some genes that are not expressed on both sides. But I'm not as good enough of an expert in that. Someone else may know, but I'm not sure.
Another question about, so how far out do you schedule a second examination appointment while monitoring leukoplakic lesions?
Yeah. So for people with leukoplekia, then and I'll give an intro. I'm not going to ask a question with a question, but when we start looking at all of our lesions patients, we divide them, and it turns out that there's between 100 and 120 categories diagnostically in the diagnostic books. Okay, so when someone comes in with a leukoplakial lesion, if you have a true leukoplakial lesion, they get characterized as well. There are leukoplakial lesions that might come between two teeth where there's been an extraction. That has a special name called a friction ridge, and those rarely become cancer. There are times when people will get a white line on the inside of their mouth from just contact of their teeth and things of this nature. That's called a linea alba. Those rarely ever get cancers. The ones that we worry about more are going to be ventrolateral tongue lesions. That's the higher risk site. And then sometimes, if the ones that have a speckled appearance to them, if they have a true lesion that has any kind of an ulceration or something like that, they're going to get biopsy just about right away. But the general, through the World Health Organization, a leukoplakia is defined as a white lesion that you can't attribute to be anything else, like a fungus infection or something like that. And then usually you try to remove the irritant, whatever that would be. And then in removing the irritant, those patients are typically examined again in about 6 weeks if they have a leukoplakia.
All right. So in terms of patient support, what resources do you recommend for those who've recently been diagnosed with head and neck cancer, and resources for their families as well?
Yeah, so the Twin Cities have had a pretty long history of good advocacy. There was something that was called the New Voice Club, and that was for patients who had laryngectomies performed. That's been active in both Minneapolis and St. Paul. Through the Oral Head and Neck Cancer Association, I think the SPOHNC is active in the Twin Cities. We have May the 4th, to put a plug in for it. We have a head and neck cancer. We have it like as a survivors conference that's done at the University of Minnesota. It's going to be the 4th of May this year on that Saturday for a morning program. So there's those types of things, but generally you almost want it to be a specific support group for head and neck, because the one thing that's always been sad for me about this malignancy is that this is the one that really can take away massive parts of your quality of life in terms of enjoying food, in terms of your physical appearance. If you're missing your jaw, you're missing your voice box, sometimes it's not that easy to integrate back into society. So it's not that easy for folks with head and neck cancer much of the time when they can't communicate well, eat well, things of this nature. I've often said, as part of the head and neck cancer multidisciplinary teams, we always talk about the social status and social networks that patients have as part of our treatment plan, and we try to be mindful of that for the whole time that patients are under our care. I've always considered at the U of M that when any of the mouth and throat cancer patients, that they have a cancer home in my practice. I'm not just treating them and then them going away after a few years. They always end up having my card. People will email me sometimes and things of that nature. I have a patient who has a recurrence right now who we're not treating, but was in my practice for 20 years, and she has a second tumor, and she's down in Tucson, and I'll weigh in with her probably 3 or 4 times since Christmas. I've been in contact with her. So it's one of those things that one would hopefully get support that they need through their family. I got a son. He's going to be a psychiatrist. He's in residency right now. I asked him one favor. I asked him if he would do a psychiatry cancer rotation when at Fox Chase. He's in Philadelphia, because I think that in a very non-judgmental way, I think it would be very interesting when undergoing these cancers. It's interesting to me that people don't automatically get at least that kind of like a behavioral health or psych liaison consult, because this is a very rugged cancer treatment that people have to go through.
Okay, love that. Thank you for closing us off on such a wonderful note. And we are unfortunately out of time. There were so many questions submitted, but unfortunately we cannot get through all of them. So we apologize in advance, but a special thank you to just everyone for the engagement, and Dr. Ondrey for joining us today and helping us raise awareness about head and neck cancers. So as we wrap up, when you close out of your Zoom window, Zoom will populate a brief survey for you, for us, and we would really appreciate it if you could just spare a few moments to fill out the survey, we would love to hear your thoughts and feedback about today's session, as it helps us continuously improve our fireside chats. And after submitting the survey, don't close the window just yet, because there is a link to enter the drawing for a chance to win a prize pack filled with goodies from the Masonic Cancer Center. And join us for our next fireside chat on Wednesday, April 15th from 1 to 2 on gynecologic cancers. We actually will be hosting this session in honor of Women's Health Awareness Month. And lastly, please follow the Masonic Cancer Center on all of our social media platforms to stay up to date on the latest announcements and events from the Office of Community Outreach and Engagement. Thanks again, everyone, for joining us today. Thank you so much, Dr. Ondrey, and we look forward to your continued engagement.
Well, thanks so much for having me today.
Of course. Bye now.
Bye.